We're live. And
yes, we are live. Hello, everyone. This is Lori with The Squeeze and Lucille, my partner in all things Squeeze, as well as our guest from the last time, Mike Metzler. He actually had a lot to say, and he gave us some foundational information regarding the U.S. healthcare system last time. So if you didn't watch our episode 10 show, you might want to go back. But today we're going to get into more of the nitty gritty, more details, and ask more questions that people have had. So Mike Metzler is the former CEO of St. Anne's Hospital in Massachusetts. And he is also a consultant, a business consultant. He is currently working on a book about the U.S. healthcare system. He is simplifying this whole crazy system that I find so confusing, and the reason that Lucille and I decided we needed to have him on the show. And he's including some pros and cons of all the different, there's so many different healthcare ideas out there that all the candidates are throwing out there. And I think that people are getting confused. And I think since this is a non-political book, it's going to help us understand the facts about each one of these, right, Lucille?
yes, exactly. And I think that's what's so important. It was funny because I was saying that when we talked just yesterday, that actually when I was watching the debate the other night, I actually had a better understanding of what they were talking about, but it was still so confusing. So, so that's the value. Mike, you're bringing a lot of value to everyone. Thank you.
Thank you.
So I wanted to get going then and start with the burning question of how are prices determined for healthcare providers in the United States?
Okay, well, first of all, I need to note that we have a system in the U.S. that has a government component, and then it also has a private component. Mm-hmm. So very simply, in the public component, both for Medicare and Medicaid, prices for physician services, hospital service, all kinds of healthcare services are dictated by the government. They're legislated or they're administratively determined by government agencies. So that's the simple version of pricing. That's the government sector. However, in the private sector, where we have private health insurance plans, there's a negotiation over prices. That mm-hmm. A healthcare plan like Aetna, like Blue Cross Blue Shield, within a geography, they negotiate with providers and reach an agreement in almost all cases on what the health plan will be paying those providers for their services. What's happened in recent years, maybe the 10 or 15 years, last 10 or 15 years, is that healthcare systems have been on the rise. So hospitals have come together as under an umbrella organization that includes physicians and so forth. So what you have is usually a large healthcare system that's negotiating often with a large insurer on what doctors will be paid, what doctors will be paid, et cetera. And there can be variation in the pricing depending on who's negotiating with who and what the geography is. You could have two hospitals in the same city that are separately negotiating. They're part of separate systems, and the pricing of those two hospitals could be different.
So that's why we're seeing all the little hospitals bought up.
Yes, and you're seeing physicians giving up their independent practices and becoming employed by healthcare systems. Part of the reason for the growth of systems is that as there's been consolidation of health plans, and they have become bigger and bigger, providers feel they have more bargaining power in negotiations if they come together as a big system and negotiate with a big healthcare plan. So there's intense, large bargaining power on both sides of the negotiation. I should talk a little bit about, well, what are prices? What do prices mean in healthcare? If you go back before the 1980s, and still to some degree today, the pricing is what we're used to as consumers, that you go to a supermarket and there's a price to buy a can of this, a price to buy a pound of that. That's a fee-for-service system if you're talking about services. So negotiations used to be every time you get an MRI, what's paid to the MRI facility. Every time you stay in the hospital, what's paid to the hospital for those days that you stay. That's a fee-for-service system. The problem with that system is that there's an incentive to do more and more.
Yeah.
Hospitals will make more money, produce more revenue. Doctors will make more money. Clinics will make more money the more they do, which works against our national desires to have lower cost. And if we're doing unnecessary things, the healthcare system is going to become more costly. So
in other words, let me just interject for a second. So in other words, they may send you for an extra test that ordinarily you wouldn't need, but it benefits the bottom line to do that.
Right, or you may be kept in the hospital for 2 more days when it's really not necessary. You really could go home and get home care services. So over time, there's been a recognition that fee-for-service has the wrong incentives. In the early 80s, Medicare introduced a new system called DRGs, diagnosis-related groups. What that means is that a hospital, for example, gets paid according to what your illness is. So if you have a heart attack, you get admitted to the hospital and you need open heart surgery, that is coded as a certain number, as a certain diagnosis, and there's a fixed amount of money that the hospital gets paid to take care of you. And no matter how long you stay, or no matter how many tests are done, or how many times the physician visits, that payment doesn't change. And so there's an incentive then for hospitals to provide care in a less costly fashion, to do less rather than do more, because they can keep whatever is left over that they don't spend out of that DRG payment.
So we have this pendulum that just keeps swinging back and forth.
Yes. So you get into the 90s, and the pricing system changed to what's called capitation. And under a capitation system, the health plans pay to the providers a fixed amount of money per month. So per member per month is what's called. So you don't look at who's sick and who's well. It's just that within the panel of members who get their services at this provider group, those providers are going to get a fixed payment per month. And again, that the incentive is to do less, not to do more.
So that is like a membership fee, because we've talked to, in our previous shows, talked to some doctors about like direct primary care, and they have a membership system. So it's similar.
It's similar.
The idea.
You have the insurer making that payment to the provider, rather than an individual under direct care making their own payment, other than an insurance payment. So what happened under capitation into the 90s was people recognized that it would keep costs down, but what about quality? Were people being charged too soon from the hospital,
right,
and not ready, and maybe they came back then in a short period of time? So that system kind of evaporated, but in very recent years, there's a variation on capitation, and there's the formation of what they call accountable care organizations, ACOs, wherein there's capitated payments, but there's also a very comprehensive system of checks and balances wherein quality is monitored and measured very closely. And to the extent that quality is not there, if patients return to the hospital, for example, after short periods of time, if people develop infections after surgery, then there's a penalty against the providers. So they lose some of that payment. On the other hand, if they're excellent in terms of their performance on quality and cost, they can keep the balance and get bonuses. And that's the growing approach now that's taking place. And so the focus now is on wellness. So we had incentives for providers, incentivized about doing more, doing things that were unnecessary, and you make more money the sicker people are and the more services you give them. When the new model is a wellness model, that to the extent that providers work together in large systems to keep patients well, they will end up getting paid more at the end. And so there's more interest now in home care. There's more interest in providing patient care assistance in the home, community health workers, people in their homes so they don't come back to the hospital, which will be very expensive and will work negatively against the income of the providers.
So there's metrics involved that keep them honest.
Yes, they're big metrics. So there's just a big, almost industry now around the collection of all this data.
Now, how many would you say, what's the percentage? Because to me, it seems like fee for service is still in effect. So I'm just wondering, in the United States, really, which one of these is the majority? Do the majority of healthcare systems follow?
Yeah,
or healthcare providers follow?
Right. So it's been a slow process of moving towards the capitated ACO model that I'm talking about. But in the meantime, there's been some variations on capitation, and actually a number of health plans have adopted the same methodology as Medicare, a diagnosis or DRG related system. It takes a lot of measurement and it's very complex under an ACO to keep all the data straight, to make sure that the capitated payments are fair, so to track the demographics carefully of who's in the membership in a plan. Hospital and doctors should get paid more for their capitated payments to the extent they have more elderly or sicker patients. It's a very complex system, and it's slow to grow. Massachusetts has been a leader in that. Blue Cross in Massachusetts is probably the biggest leader in doing that. I happen to be the CEO of Blue Cross, happens to be a friend of mine who I have a lot of regard for, and really cares about people and patients. And he's been a pioneer in bringing this forward.
It seems like doctors are getting back. Isn't that why doctors want to be doctors, is they want to care for people? I think this is coming back to the wellness part. So, and doctors seem to not be so into all this preventative medicine. And is this driving doctors to be more open to alternative medicine?
I think it is. The difficulty, though, in the American system is that we have so many different private health plans, and people move around a lot. So alternative medicine, some of the, in terms of nutrition and so forth, the good effects of all that take place over a longer period of time. And so health plans are not necessarily that interested in providing that, paying for that, because a lot of their people just move to another employer, or at open enrollment time, they pick another health plan.
Insurance plan.
I'll probably talk a little bit more about this later, but in a single payer system, that's more achievable because everybody's in the same plan for a long period of time, and over a longer time period, you can see the positive impact of that. In the meantime, in the U.S., there has been a growing movement of employers providing benefits around wellness, and whether it makes a difference or not in their insurance payments. On the other hand, it keeps their employees happy, motivated, healthier, not as sick, and coming to work more often, being more productive, and the employers become more attractive because they offer that, because there's just such a growing interest in these things that people want it. They want to work for an employer that might provide those opportunities, even during working time.
Yeah. So this is what I'm taking away. So healthcare, the costs, it depends. It depends on like what system you're with, what insurance, because they're negotiating, and the bigger the conglomerate, the better the prices. And so it really kind of depends. There isn't a consistency.
Yes, and it's a big issue in Boston where there's a lot of teaching hospital systems that they have a lot of clout in their negotiations because every health plan wants to have those hospitals in their plan.
Right.
Hospitals have stronger bargaining power because of their reputation and so forth. So they can command higher pricing, and that is in conflict. I'll talk about Massachusetts, that with what happens out in community hospitals. So people are attracted to a large teaching hospital, and they'll travel to that hospital even for basic things, some basic surgeries like gallbladder surgery that they probably could have done just as effectively in their community. And even when they do it in their community, it's actually cheaper. The prices are less because that community hospital doesn't have as much clout in its negotiation. So there's a lot of variation in pricing.
Too many variables.
Yeah, too many variables that are actually, contributing to the price going high.
Yes.
So let me ask you about prescription drugs, Mike.
Yes.
That's a question a lot of people have. Why, how are the prices for prescription drugs determined?
In the U.S., it's just the free market system. There's no negotiation over that. And in other countries where you have single payer systems, the government negotiates with the drug companies and gets lower pricing. And the numbers show that compared to I'm talking about high income, well-developed countries, Western European, that drug pricing there is drug prices are half of what they are in the United States.
Awful.
So is this just capitalism? I mean, these pharmaceutical companies just make an exorbitant amount of money. I mean, I have friends who are pharmaceutical reps, and they're all very high paid people, travel a ton. They spend a lot of money on those people going to hospitals and doctors selling those drugs. Right.
It's a terrible issue. That a lot of it is political in Washington, and the lobby that the drug industry has in Washington. We wouldn't have to go to a single payer system to negotiate. There's actually a bill before the Congress right now to do that, and other limitations, regulations on drug pricing. Just think about Medicare, which is huge. There was an attempt through the Affordable Care Act, Obamacare, to make part of that legislation that Medicare would have the right to negotiate with drug companies, and it didn't make it through. So there's no negotiation, and it's very complicated. But then I could talk for an hour about this, that just how prices are set at your local drugstore, and list prices versus discounted prices, and coupons and all that. People who pay cash and don't have insurance for drugs have the opportunity to go on websites, for example, like GoodRx, and get a coupon and pay substantially less than what the list price is at the pharmacy. And I've had recent experience with this. My wife has had recent experience. It's been a real eye-opener. So I myself have done sort of more research. There's these brokers between the drug companies and they're called pharmacy benefit managers and the drugstores, and they control the market to a great degree. But again, I don't want to take up a lot of time on that.
Yeah, but that's pretty fascinating. I mean, that's fascinating for somebody who can't afford insurance. They actually have the option. I bet a lot of people don't know that, to go to the pharmacy and say,
you can't, right? They don't know it. So you go to
do for me.
pick up your prescription you don't have any insurance, and they tell you it's going to be $250.
Yep, been there.
Good RX, and there's a coupon there, and you can get it for $25.
That is crazy.
In my experience, I won't mention the pharmacy. My experience was when I questioned the price, the person said to me, well, you can go to Good RX and get a coupon. I said, well, tell me how I do that. She said, you don't have to do it. She said, I'll do it for you.
Wow, Mike.
We knew right there at the pharmacy that the price they were about to charge me was substantially more than they could arrange for me to get without much trouble.
And it's absolutely the same drug.
Absolutely, yes.
Wow.
Yep. And
so these are the things consumers don't know. It was just like Dr. Foley had talked about going to urgent care, and that you can, to a certain degree, negotiate your fee there. And that it's just wrong. Right. So anyway,
I even had a doctor send me to Canada. He said, because I said I went to get some hormone therapy at the CVS, and they're like, I think it was $350 for 2 prescriptions for a month. I said, I can't afford that. And so when I went back and told the doctor, he says, well, here's a website where you can get the drugs through Canada for a lot cheaper.
Yes, that's sort of a cottage industry in our country that it's actually illegal, but the government looks the other way on it.
Yeah.
Okay. Interesting.
All right. Now we're going to get to the nitty gritty here.
Well, Christy has a question, or do you want to?
Yes, go ahead.
Okay, so let's make sure we get a question from one of our viewers. Thank you, Christy, for being here. This is actually regarding the coronavirus, so it's a good question. At some point, I would love to hear thoughts about how to improve the U.S. coronavirus response, data sharing about it, that kind of thing. Considering the fragmented healthcare system, do you think the U.S. will be less effective at addressing this issue than countries with single-payer systems?
I really can't answer that. If I tried, it wouldn't be right, because
maybe we can find someone to answer that question for you.
Maybe offer some things to think about. In our country, we have the solutions for these possible pandemics are developed through the leadership of the CDC. And so which is a government agency. So as we're looking at it right now, we're talking about just how good are they at doing this. And so if people want to research it, it would be, well, how exactly are other governments doing it? Are they doing it better because they have a single payer system that's run by the government? Is the government more attuned to attacking these? I really don't know.
Okay.
I would offer that as a way to sort of investigate it in that regard.
Well, and they're claiming that they have this under control, and we have systems in place, and I frankly don't trust what they're saying.
Well, I don't either, but I don't want to be political.
Okay. Yes. Let's move on.
All right. I have a big question I want to ask. The meat of it really here, and that is, what is the different types of healthcare insurance plans, and how do they work? Or have we kind of addressed that? I mean, I think that's
sure. I think a lot of people are familiar with those because their employer usually offers different options. So I can, first of all, just have a regular commercial plan and it's usually more expensive, where I can go to any provider that I want to. Those are the more expensive plans. An HMO is a health maintenance organization, is a plan wherein there's a limited number, there's a network of providers within that HMO, and you're limited to limited to stay within that provider network. If you go outside the network, you're going to pay 100% for care.
Right.
Then there's a third type called a PPO, Preferred Provider Organization, and that has its own HMO-like network. But if you go outside the network, you don't pay 100%. You pay perhaps 25%. So essentially, the pricing of health plans, when you talk about the different types, is such that you're going to pay more for a plan where you can go anywhere. you're going to pay less for a plan that you can only go to certain places. And if you go outside, it's going to cost you 100%. And you're going to pay a little bit more than that for a plan that still allows you to go outside of the network, but you're going to not have to pay the full amount. So when people make their decisions, they really need to look closely at who the providers are in the networks of the various plans. Is their doctor in it? Is there a hospital that they prefer in it, and so forth? So we end up paying more or less for a healthcare plan depending on the extent to which we have choices. So it's call it choice.
Less choice,
pricing.
less expensive.
Yes. Yes.
Yeah.
Mm-hmm.
But really, how much control do we have when that's determined by our employer?
Yes, I talked about this last time.
Yeah, right.
People don't want to lose their health plan, but I really think what they're thinking about mostly is they don't want to lose their provider.
Mm-hmm.
Yeah.
They want to keep their doctor. Remember that discussion?
Yes, definitely.
The campaign when President Obama became president, he got in trouble with saying, you can keep your doctor, and that's not true in all cases in all plans. So,
well, plus you have such a limited amount of time when you are given. Here's your package. We're changing the insurance at the end of the year again. It seems like it comes up like that, and make your decision now. I mean, it's so overwhelming.
And then seniors, in terms of Medicare, going through an open enrollment for Medicare every year, looking at what kind of plan they want. Do they want to stay in basic Medicare? Do they want to get a Medicare Advantage plan?
Right.
Which drug plan D, should they choose? There are good calculators on the Medicare drug site Medicare site that you can put your drugs in, and for each plan, you can figure out what it's going to cost you within a year.
Good to know.
But there's so much complexity in all of this, and I would say that becomes an equality issue when you think that how good at it you are is going to depend upon your cognitive ability, which is sometimes compromised for seniors. It's going to depend on your income. You may not be a person who has an income where you have the technology to be computer literate and all of that. So complexity brings about inequality, I would say.
I like that. You're right. Complexity brings about inequality. Right.
So can you talk about the different proposals that the different candidates are putting on the table, trying to confuse us, and all they do is, badmouth the other guy instead of just tell us the facts, let us decide.
Sure. So you said, yes, they just badmouth the other guy. And my problem with all that is they're talking about it at a 30,000 foot level, getting into the detail of how it affects individuals and how it affects their health by going one way or the other. They're talking about cost mostly, which is certainly very important. So let's start with Medicare for all. And two of the candidates are talking about that, Bernie Sanders and Elizabeth Warren. And that would say, in that proposal, we would get rid of the private insurance sector, that we would have only one health plan in America, and it would be Medicare. So right now, people age 65 or over on Medicare. So we transition into a single payer system, and the single payer would be the Medicare program. There's pluses and minuses to all of that. I should say that I should have said this at the beginning, that every plan that is being talked about by the Democrats the assumption is universal health care. That right now we still have, in spite of Obamacare, we still have about 28 million Americans who are uninsured. So whatever option that is being proposed by a Democratic candidate, that option, the goal is universal health care. Everybody has insurance of one form or another. So that's Medicare for all. Eventually, everyone would be under Medicare. The second proposal is that that we would continue with the system that we have right now, private insurance system, but we would expand Obamacare and to try to bring that 28 million number down to close to zero. That when we started with Obamacare, we had about 46 million Americans uninsured. Now we have 26, 28 million. So how do we bring that number down? So in Obama, you have to understand Obamacare to know what the expansion of Obamacare would mean. That's talked about, the expansion of Obamacare. The expansion would be that you change a number of the rules under Obamacare that would give more opportunity for people of certain income levels to buy affordable health insurance. Right now, the rules show that, first of all, if you're below a certain income level, which is about 130% of the national poverty level, you can have Medicaid for free or for some reduced amount. But once you get to a certain income level, then you can not get Medicaid, but you can get a tax credit. So the tax credit would be for people that are, from 100% higher than the poverty level to 400% higher than the poverty level, that they could, in fact, get private health insurance, but get a tax credit of a certain amount that would be on a sliding scale dependent on their income. And the way it tops out is that that you would end up not paying more than 9.8% of your income for health insurance. So the proposal to expand Obamacare would be that you would change it all so that anybody would be able to get tax credits of a certain amount. There would be no limitation at the 400% of the poverty level, that almost everyone would have an opportunity to get health insurance, tax credit for their health insurance, and you'd lower that 9.8% to 8%.
How much does that cost?
What? How 8%?
No. How much does that cost to drop that?
I don't know. I mean, there's so many proposals out there as to what the cost of the various plans are. The one I'm most familiar with is Medicare for All, what people are saying about that. Also, this is the Joe Biden approach. Besides doing what I just said about expanding Obamacare, his proposal would include other elements like being able to negotiate with drug companies and a number of other things that would make healthcare cheaper overall in the country. So it's Medicare for All, the expansion of Obamacare. The third item that's being talked about is a public option. That let's keep the private system and have private insurance, but let's create a new insurance plan that's public and have that compete with the private plans. So my employer could say, these 3 health plans that are private are available to you, but now also you could, in fact, pick this public plan, and this would be the cost of the public plan. So the idea would be is create a public plan that would be cheaper than the private plans, and people could pick that plan among the private plans. Some of the thinking around that is that would be a transition perhaps to Medicare for All at some point, that everybody would go to a public plan. So a big part of the discussion is the country really ready to all of a sudden go into a single payer system, namely Medicare for All, or do we need some sort of transitional type of change that gets people sort of used to buying their health insurance or getting their from a public source rather than from a private source. On the Medicare for All proposal, there's a recent study that came out, Bernie Sanders talked about it the other night, from Lancet, a highly regarded publication that does research. And in that study, it said that if we went to Medicare for All, the country would actually save $500 billion per year. And the way it works, I won't get into the whole thing, but so you take Medicare. Medicare, the administrative costs of processing claims in Medicare is around 3%. On average, the cost for private plans is about 15%. Either way, you'd save significant money there. The other major way you'd save money is that provider pricing would all change to what Medicare pays providers. So what doctors and hospitals get paid would be reduced. Doctors and hospitals are not happy with whether they would about Medicare, pricing. So a big question about whether that could ever be, would ever work. And there are just a lot of other elements that are said that would reduce the cost of health insurance. Another is that when we get to a fully insured country, people who are sick will be using their primary care physician. They won't be taking episodic care through an emergency room when they're really sick. They'll be getting, preventative care and all that. So there's a lot of theories on what would bring the cost of health insurance down in Medicare for all, but other people's estimates are all over the board, and there's a lot of questions about the assumptions in that particular study. But overall, the way Medicare for all would work is if private insurance went away, the government would be the single payer, and the way it would be paid for is through higher taxes. So instead of me having money come out of my paycheck for my health insurance plan, I wouldn't have that anymore, but I would be paying higher taxes. So that becomes a very controversial issue among the candidates. Mm-hmm. People would ask Elizabeth Warren, tell us, will taxes go up? Ask Bernie that, all that. The fact of the matter is, yes, they would. But then it gets to, well, who's going to pay those increased taxes? Some of the candidates would say the middle class may pay a little more, but not a lot more, and they'll pay less than what they're paying now for their private insurance through their employer. And the wealthy would be the only ones that are taxed. So the issue becomes kind of who pays for it if we go to Medicare for all. I hope that helps, and it's my simplified version to the extent that it's simple.
So the fact that how much people will pay seems to be, that's a big question.
Mm-hmm. Yes, it's definitely a big question. So that's a big question. The other big question is, do I want my government making decisions about what my health insurance plan is going to look like? Mm-hmm. Bernie would make the Medicare for all plan be such that there'd be no deductibles, no co-payments, and you could go wherever you wanted. That could be a very expensive plan. In other countries that have single payer systems, in Germany, for example, people pay for a portion of their health insurance still. The government doesn't pay for everything, and there are co-payments and deductibles. So it's all about the design. We're not in the discussions getting very deep into the design, but the outcome is very dependent on the detail.
Yeah, I would think so. So, I mean, how do you make a decision? I think it's just so difficult when you don't know the details.
And nobody really, actually, the candidates can't talk about the details because the details would have to be worked out by Congress, and nobody can really predict that.
Whoa. So tell me a little bit about Germany. I'm curious because how come their system is so good? And I kind of like the idea of that being able to pay privately if you want, or, get private insurance.
Here's how the German system works. The insurance system is still an employer-based system. Remember, I talked about that last week, that in our country, we have employers directly paying for health insurance.
Yeah.
So in Germany, employers are obligated to provide health insurance, and they have to pay a certain portion of it. They all pay the same, and it's a single payer system that they pay into. It's not socialized medicine. The government is the payer, and the amount that the employees pay is about 8% of their income. So unlike in America, in our employer-based system, most employers, everybody pays the same no matter what their salary is. In Germany, it's income-based, which brings about more equality, that more higher paid people pay a higher dollar amount or higher mark amount. When your income is over a certain amount, you're eligible not to participate in the national system and to buy private insurance. But
I like that.
That's only
That
available.
makes wealthy people happy.
I'm not quite sure about this, but I think that level of income in American dollars is somewhere around between $70,000 and $100,000. So they have universal health care in Germany. You know, that by itself distinguishes any country other than the US, that everybody has insurance. And then from there, it's a matter of how they get it. And in Germany, that's the system.
Interesting.
Is there a system in the world that most people say that's the great, that is it, that's the best we've got in the world?
In what I've read, I hear Germany and France being mentioned mostly. Okay. And it comes down to universal care. It comes down to cost. It comes down to quality too. So there's a lot of measurements about the quality and waiting times in different systems and the outcomes. So we look at outcomes in our American system and quality, and we find that we're down the list. We think we have the best healthcare system in the world, and outcomes are poorer in America than in a lot of other countries. That we just take life expectancy. We're the lowest life expectancy of the 11 richest nations in the world. And we among those nations too, we have the poorest infant mortality rate. And the list goes on. And so again, looking at the best systems, the measurements are around equality, universal health care. I said equality, not quality, but also quality. Waiting times, there's an assortment of measures, a lot of good studies on that. In Germany and France seem to come out near the top all the time.
So why can't we just take all these systems? I mean, is this just simplifying it too much in my perspective, that we take all these systems and we've got things that are already working? Why can't we take those and fix this issue? Why is it so complicated?
Absolutely. It's complicated because it's political. That's why it's complicated. And, it's hard in a major presidential campaign for the candidates to get into the issues. There's not the time for it. People want to take the time and look at their websites. You can get a lot of the detail. Last night I looked at Joe Biden's, but I'm not saying I support Joe Biden, but I just took a look at that one, and I thought it was pretty comprehensive. So, and Bernie Sanders, I know is Elizabeth Warren. She's very comprehensive about just about everything. So I assume that's a good one. So that's what you really have to do. But then when the rubber hits the road after the election, what happens will depend on the politics, will depend upon Congress. And we know we have right now we have a case that's pending before the Supreme Court that would possibly eliminate Obamacare entirely. And the one area of Obamacare that I worry about the most being eliminated is pre-existing conditions. What if we go back to states being allowed to have insurance companies deny people coverage if they're sick?
Yeah, I mean that should be un-American. I mean that's I shouldn't say just un-American. That's just not being a human being. To deny people, to deny people health care just because they have a pre-existing. And like I think I said last week, I mean, everybody over a certain age has some pre-existing condition. So,
I'll vouch for that.
Yeah, so that's very scary. And that's in front of the Supreme Court right now.
Yes.
So as individuals, Mike, I mean, what do we do about it? I mean, I mean, getting informed is huge, and that is going to be the value of your book. That's the value of your being our guest, and explaining these things to us. But is there anything more, I wonder, that, we can be doing?
Well, you're absolutely right. Being informed that, and policymakers really need to be informed, because when you're talking about healthcare, making the wrong uninformed decision, making mistakes, it has real consequences for people's lives. So it's a dangerous game. from there, it's a matter of people getting active and groups getting active and all that. That's really, so take something like climate change. Look at what's happening now. Younger people are really energized about that.
Yeah.
They're opening their eyes to, this is going to affect us. This is our generation is going to feel the impact of this. So how you organize people and get people energized. I lived during the 60s, so I guess I saw what protesting and being active do and how it changed how we do things. You look at the Civil Rights Movement and the Civil Rights Act, what's happened with women and the Me Too movement. Those kinds of things need to happen.
Right. I think I'm ready to run out there and protest. Mm-hmm. So Christy asked the question, do we as a nation just hate science and research? Well, unfortunately, the current president seems to hate science and research. Why aren't the statistics about mortality, for example, persuading everyday citizens to seek change? Mm-hmm. It's a good question.
Yeah, I really don't know, but I wish the candidates, at least the Democratic candidates, would start throwing those out more often.
Yes,
right.
Data makes me.
I don't know about you, but those debates are really, really hard to watch. You don't learn much from them. So I watched the debates on, was it Tuesday? And then last night I watched the town meetings. And wow, it's a whole different feeling about the candidates. You learn a lot. They get into a lot more detail. Finding some way within the media to get a lot of these facts out could make things more compelling. I don't know.
That's what we're doing here, right?
That's what we're trying to do.
Yeah. Mm-hmm.
Get the information out, and that's what you're trying to do. And we need your book.
Yeah. So
everyone needs a copy of your book.
I can't believe we're talking about a book that doesn't exist. So I better get moving.
Well, it's in process.
I'm close. In the meantime, I'm happy, as I've mentioned to you, that to go out and talk with people. If anyone would like me to come out and talk somewhere,
if you need a speaker.
And my email is metzler.mike@gmail.com, metzler.mike@gmail.com. Please be in touch. I'd love to go out and talk about this, and small groups, large groups, individuals, whatever. Maybe I can help.
Right.
People active and getting people energized about this.
So we also have another question from Christine Rasconi Holmesy. You must know her.
I do.
Whatever health plan you choose, the provider bases their billing on codes. Is there a way to understand what is an accepted code for treatment that is being prescribed before you get the extra charge in the mail?
God. The whole coding system is really, really complicated.
Yeah,
I can remember years ago, I'm not saying the wrong thing here, but I can remember emergency room physicians being trained on how to upcode as much as possible. And, understanding coding it's so complicated. It doesn't hurt to ask the doctor about that, or the nurse practitioner, is have them explain just what they're putting in on the record in terms of what your condition is or what you were treated for. Have them explain it to you. There's nothing wrong with asking that. The whole system of just the charge, there's a whole charge system, at least in hospitals, where the price is much higher than what the insurers end up paying. And if people are uninsured, or they're going to get charged the list price. It's just like what I talked about in terms of drugs. But people then people end up getting surprise bills later on for something that wasn't covered. So we need to start asking our providers just, what is it going to cost me as it's happening? And what are you putting down for the code for me that, and they'll say to you, well, I'm putting down that you have such and such and need to have such and such. And the payment is based on me saying that. I think the more dialogue there is between the patient and the provider on that, the better off we will be.
Well, I've in a previous show, we talked about my dermatologist and how we were charged totally different. Two of the same exact procedures done for me and my husband, and they were charged. One was 10 times more than the other, which spurred me to call. So now I have this, as you say, open dialogue with my laboratory, with the doctor, and I've gone to the same dermatologist because we've worked all this out, and I got a new bill. But now this is why it's so complicated. Now the dermatologist has merged with a bigger dermatology conglomerate. So now my bill is different, the way that it's coded, and everything's different. So now I have to go back to the billing guy and say, I can't even compare apples and oranges here, right? So now I need you to explain this to me. And they're like, oh, here comes that woman who drove us crazy for 3 months. 3 months, I drove them crazy.
Yeah, so different providers have different policies around to what extent they take risks on on codes and how high of a code, because what will happen is the insurance companies come in, they'll do an audit, and they'll look and they'll down code after something's, if they feel it's been overcoded. On the other hand, providers and patients are suspicious of what the insurance companies allow. So I'm sure people have run into this where you want to get a lab test and the doctor has to show that it's medically necessary. Say you're interested in your B12 level. The doctor has to put something in, or the provider has to put something in that they've learned that indicates that you may have too low of a B12 level. They have to show that it's medically necessary. So I can't just go in and say, I'm really curious, doctor, about my B12 level. I really wish I could have it checked. Well, if you want to have it paid for, the doctor has to give some medically necessary reason for it. I mean, I've had it where I've had providers say, well, I'll put down such and such so it'll get paid for. So again, the complexity of the system is just so complex. And that results, as I said earlier, in inequities and so forth. Anyway.
So have we overcomplicated it? I mean, can it be simpler, or does it need to be this complicated?
I don't think it need. I think a single payer system would solve a lot of that. The rules would be the same for everybody. A big part of what happens in a physician office is they face really at a disadvantage. They have every different rules for every lab, and different rules for every single hospital, every single provider, every single test. The rules are all so different. They have to keep track of them. They have to be sure they say the right thing.
Yeah, they seem exhausted.
There's not one set of rules.
Yeah.
The complexity of it all. If we had fewer rules and they were all the same, then yes, it would be much better. And I think a single payer system, you have a better chance for that.
Yeah.
Christy had just typed up, "Go Squeeze Go." I want that book too.
So more incentive for you to get that book done, Mike.
All right. Well, the more pushing I get, the quicker it'll be.
I'll be sitting on your front lawn. I'll be sitting on your front lawn soon.
No, I'm going to text you.
Yeah, I keep coming up with new thoughts and all of that. So I have
the second book.
Yeah.
That's the second book.
We'll help you organize your thoughts.
I'll get there. I think I'm within a few weeks of it. I'm getting first draft. I have a first draft, but finally getting it out to an editor. First thing I have my wife Peg. I need to have her read it, but when she's going to read it, I don't want to embarrass myself. I want to make sure it looks good before I just hand it to her.
Oh, Lucille, let's talk about Peg. Let's talk about a future episode.
I want to ask a question before we talk about Peg. Okay. I think it's a great idea. But Mike, have we missed anything in terms of some of the latest ideas on reducing healthcare?
No, I have a whole list of things that, and I think probably they come out in one fashion or another, that need to be fixed. There's a lot that can be fixed without having to turn the system on its head. and
That's encouraging.
Yeah.
and we can fix a lot of equality issues too, legislatively, in terms of giving maybe more government support to people at higher income levels to pay for their health insurance, to make health insurance that's available now more affordable for people. There's things that we can do there. We can work on the cost side, on the pharmacy side. We've talked about that. Yes, there's a lot that can be done short of reforming the whole system. I think that my view is America is not ready to turn the whole healthcare system on its head. So we need to find some transitional ways of bringing about change, that people start seeing that we can do better. And then maybe eventually we'll have Medicare for all, single payer system. But overnight, it's going to be a hard thing for, I think, the public to accept. And I think rightfully so. It's about their health. It's about their lives. It's about their families. And they want to be careful about change. And I think we can do a lot to make things better without creating a whole new system.
Good point.
And I think all the candidates and all the legislators need to talk to you, Mike. Find out the things that can be done.
Well, I'm available, so.
Yeah, well, that sounds good to me.
Well, one of the things that we seem to be as a society caring about, I mean, Christy's asked a lot of questions. I mean, she's very on top of wellness and how to take care of ourselves, and does research on what to eat and what to take. And we're all into that. And I've heard that your wife is into wellness. So how do we incentivize wellness to make things better?
Yeah, I think health plans should have elements in them that are incentivize people, pay for these things, and so forth, make those services available. By the way, I'm not talking about wellness necessarily, but one thing I don't want to forget to mention is mental health. That there's an area where we can make improvements immediately without changing the whole system. We're just not treating mental health like we are physical health. There's a lot of proposals around at the legislative level to deal with that. We can deal with that. On the wellness side, there's so much that we can build into health plans. There's so much that employers can be doing. I think people should be, within their place of employment, should be bringing the subject up a lot more often. I think that by itself would help a lot. Peg, my wife, is a nutrition and a health coach, deals highly in nutrition and exercise, and she's helped me a lot. Here I am in my 70s, and I'm just learning about bad food and good food. And I did one of her cleanses. Lucille knows about that. I lost 10 pounds in a week, and I wasn't even thinking about losing it. Needed to lose it. But I had already lost 15 with her help in a sort of a gradual way. So here I was, after a few months of marriage, having lost 25 pounds, working on my blood pressure, getting more exercise. So it's opened up. For me at my age, I've opened a whole new life for myself, thanks to Peg. And
we'd love, we were thinking that, right, Lori? We were talking about, how great it would be to have maybe next time we're on. I think it's March 12th. Lori?
March, yeah. What was 12th? Yes, 12th.
To have Peg come in.
Her book. How about if I plug her book called?
Yes, Wellness in You, right?
Yeah. Well, no, that's her website.
That's her business.
Food Becomes You.
Yes.
Food Becomes You. Peg Doyle, and you'll find it on Amazon.
Yeah, and I've read it, and it's awesome.
It's a short book.
Come on and talk a little bit about.
It's not like reading a 300-page book on nutrition. You'll get things easily out of that you'll want to do. You won't read it and then say, "Oh my God, where do I start?" You'll know exactly what to do after you read her book.
See, and if we're incentivized to read things like that, we go into our job, we're going to go in where we want to get a job with this employer, and we say, hey, what are your wellness plans?
Yes.
Drive the change that way.
Yeah, employers starting to recognize that it's a recruitment tool for them in a hot economy like we have, where it's hard to hire good people. Yes, people want that.
Yeah.
So we'll have to look into, I'd love to do that next time, that maybe both you and Peg would join us.
Sure.
And it would be an interesting, that would be a nice show.
Yeah.
You know, because she comes from from the more holistic model.
Correct.
She's also a Reiki and Shiatsu.
Yes, I get free treatments. How lucky could I
Oh, you are a very lucky man.
Here I am. We've been married less than a year, so how lucky am I to have found her? Wow.
It is a beautiful thing.
Yeah, yeah.
Right.
I'm very grateful.
Yeah. So anyway, that sounds like a good plan. Yeah, I mean, the information, Mike, is invaluable that you have shared with everybody. I just wish it wasn't so hard, and I think that basically it is going to have to be a grassroots campaign.
I think so.
This changed, and we cannot allow. Hopefully, the Supreme Court will not vote to take away, pre-established conditions.
Yes, yes.
I mean, that would be, pre-existing conditions, because that would be really a terrible.
Yes.
Yep.
So anyway, so anything else, Lori?
I think we can wrap it up.
I think we can wrap it up, Mike. Thank you so much.
Oh, you're welcome. My pleasure.
Yeah, it's awesome. So people, if you want a great speaker, then contact Mike at, say it again, Mike.
Metzler.mike@gmail.com.
Right.
We'll put it in the comments after the show. I'll put
Yeah. Yeah, that'd be awesome. All right. Well, we want to thank everyone who's watched us live, and for everybody who will watch the replay, we thank you. Please share it with friends and family, anybody who you think would benefit, and I think everybody could benefit from this information. And subscribe to our YouTube channel, and you'll be notified of future shows. So we thank you all.
Thank you for watching. Thank you, Mike.
Bye-bye.
Bye.